What happens when a doctor dismisses a black woman's severe pain as exaggerated, refuses to order tests she's specifically requesting, and talks down to her like she doesn't understand her own body, only to discover 30 minutes later that she's Dr. Nicole Lawson, the cardiovascular surgeon who literally owns 40% of the hospital he works at? This is a true story from 2021 that didn't just humble one arrogant physician. It sparked a complete overhaul of how one Chicago hospital trained staff on implicit bias and patient care. And the twist at the end will leave you stunned. It's a Tuesday evening in September 2021 at Riverside Medical Center in Chicago. A woman walks into the ER complaining of severe chest pain, shortness of breath, and radiating discomfort down her left arm. Textbook heart attack symptoms. She's 47 years old, composed despite obvious distress, and she tells the intake nurse clearly, "I'm a physician. I know my body. This feels cardiac. I need an EKG and troponin levels checked immediately." The nurse pages Dr. Kevin Morrison, the ER attending on duty, a 39-year-old who's worked at Riverside for 6 years and has a reputation for being clinically competent but interpersonally dismissive, especially with patients he perceives as difficult or demanding. Dr. Morrison walks into the exam room, barely glances at the patient, and reviews her vitals on his tablet. Blood pressure slightly elevated but not critical. Heart rate in the 90s. He asks a few perfunctory questions while typing notes, his body language screaming that he's already made his diagnosis. "Ma'am, your vitals are stable. This is most likely anxiety or maybe acid reflux. Chest pain in women your age is usually not cardiac, especially without significant risk factors. I can give you something for anxiety and a prescription for omeprazole." The patient, Dr. Nicole Lawson, though Morrison hasn't bothered to fully read her chart, stays calm but firm. "Doctor, I'm telling you this is different. I have a family history of heart disease. I'm experiencing classic MI symptoms. I need cardiac enzymes drawn and continuous monitoring." Morrison's response is textbook medical gaslighting, something black women experience at devastating rates in healthcare. "I understand you're concerned, but I'm the emergency medicine physician here. I've seen thousands of chest pain cases. You're presenting with anxiety, not a heart attack. If you're a physician like you say, you should know that jumping to cardiac causes without clinical justification isn't appropriate." He literally uses air quotes around the word physician, his skepticism obvious. Nicole feels her chest tightening further, whether from her actual condition or from the rage of being dismissed. She can't tell. She tries once more. "I am specifically requesting, as a patient with decisional capacity, that you order a troponin test and EKG. I'm not asking for narcotics. I'm asking for basic cardiac workup." Morrison sighs like she's wasting his time. "Ma'am, I'm not going to order unnecessary tests because you Googled symptoms. I'll give you the anxiety medication. If symptoms persist, follow up with your primary care doctor." Morrison leaves the exam room, and Nicole makes a decision. She pulls out her phone and calls someone directly. Not a lawyer, not a patient advocate, but Richard Chun, Riverside's chief medical officer and her close colleague for 8 years. "Richard, I'm in your ER being refused basic cardiac workup despite classic presentation. I need you to come down here now." Richard, who knows exactly who Nicole is and what she represents to this hospital, sounds alarmed. "You're where?" "Nicole, are you okay?" "I'm coming right now. Don't leave." 5 minutes later, Richard Chin bursts through the ER doors with 2 other administrators, looking panicked. He goes directly to Nicole's exam room, and the nurse at the desk does a double take because the CMO doesn't usually personally respond to ER patients. Richard examines Nicole quickly, his face growing more concerned by the second. He steps out and calls for Morrison, his voice sharp. "Dr. Morrison, I need you immediately in exam room 4. And bring a crash cart." Morrison arrives looking annoyed at being summoned, but his expression changes when he sees the CMO, 2 hospital administrators, and his patient from 5 minutes ago, now hooked up to monitors that Richard has personally placed. Richard's voice is ice-cold professional. "Dr. Morrison, do you know who your patient is?" Morrison shakes his head, clearly confused and increasingly nervous. "This is Dr. Nicole Lawson. She's a cardiovascular surgeon. She trained at Johns Hopkins. She's published over 40 peer-reviewed articles on cardiac pathology, and she owns 40% of this hospital through her investment group that saved us from bankruptcy 3 years ago." The color drains from Morrison's face, but Richard isn't done. More importantly, she came in with textbook MI symptoms, identified herself as a physician, specifically requested appropriate workup, and you dismissed her concerns as anxiety and accused her of Googling symptoms. You've been working here 6 years. She's been on the board of directors that entire time. You've literally presented cases to her in M&M conferences. The monitor starts beeping rapidly. Nicole's heart rate is spiking. Richard makes a snap decision. Get her to the cath lab immediately. This is a STEMI. A STEMI, ST elevation myocardial infarction, a massive heart attack that, if Morrison had bothered to order that EKG, would have been caught 30 minutes earlier. Nicole undergoes emergency cardiac catheterization. She has a 95% blockage in her left anterior descending artery, the widowmaker. The cardiologist who performs the procedure tells her bluntly, "If you'd waited another hour, we'd be having a very different conversation. You could have died because that ER doctor wouldn't listen." Nicole survives, spends 3 days in the cardiac ICU she helped design during the hospital's renovation, and returns to work 6 weeks later. But she doesn't return quietly. She demands, and receives, a complete investigation into what happened and why. The investigation reveals Morrison's pattern of dismissing female patients' pain, particularly women of color, at rates significantly higher than his colleagues. Over 18 months, 7 formal complaints had been filed about his dismissive attitude, but none resulted in serious consequences beyond a verbal warning. The hospital's review board, now chaired by Nicole herself, doesn't fire Morrison, but they do something more strategic. He's required to complete 100 hours of implicit bias training, shadow 3 female physicians of color for a month to understand their perspective, and participate in a hospital-wide documentary about his mistake and what he learned from it. The video, used for mandatory staff training, includes Morrison's own admission. "I saw a black woman telling me she was a doctor, and I didn't believe her. I saw her describing symptoms, and I assumed she was exaggerating. I nearly killed someone because my biases were stronger than my medical training." But Nicole pushes for systemic change beyond one doctor's rehabilitation. She leverages her position on the board to implement new protocols. All patients requesting specific tests must have those requests documented, and refusal must be justified in writing. Patient advocates are stationed in the ER specifically to intervene when patients feel dismissed. And most significantly, Riverside becomes the first hospital in Illinois to require quarterly implicit bias training with measurable accountability. Staff who show patterns of discriminatory care face mandatory review and potential termination. Within 2 years, patient satisfaction scores among minority patients increase by 43%, and complaint rates about dismissive care drop by 60%. Nicole gives an interview to the Journal of the American Medical Association 3 years later about the experience. Her message is powerful. "I had every advantage that day: medical knowledge, financial power, professional status, and personal connections to hospital leadership. I nearly died anyway because one doctor couldn't see past his biases." Now imagine the black women who walk into that ER without those advantages, whose pain gets dismissed, and who don't survive to tell the story. That's who I made these changes for. Here's the devastating truth Nicole's story exposes. Medical racism isn't just about access to healthcare. It's about whether you're believed when you're in the room. Studies show black women are 22% more likely to die from heart disease than white women, partly because their symptoms are dismissed as anxiety, exaggeration, or drug seeking. Nicole had a medical degree, hospital ownership, and the CMO's direct number, and she still almost died because a doctor wouldn't listen. The lesson isn't just about one arrogant physician. It's about a system that trains people to trust their assumptions more than their patients' words, and how those assumptions kill. If this story made you think about who gets believed and who gets dismissed in medical settings, hit that like button and share your own healthcare experiences in the comments. Have you ever felt ignored by a doctor? Subscribe for more stories that expose systemic bias and the people fighting to change it. Because sometimes the patient you dismiss is the person who signs your paycheck, but more importantly, they're always the person whose life depends on you doing your job right. And that should matter whether they own the hospital or not.